I'd like to invite Dr. Al Vitale to the podium to discuss treating uveitic macular edema.
Thank you, Janet, Dr. Rao, and the organizers for inviting me to speak. These are my financial disclosures. Uveitic macular edema is a very common structural complication affecting all anotopic types of uveitis and is a leading cause of visual impairment. In the MUST study at 2 years, more than 40% of patients had unresolved macular edema, and greater than 2/3 of those in the systemic arm required one or more adjunctive corticosteroid injections. The control of underlying inflammatory disease is the first step in the management of uveitic macular edema with local or systemic corticosteroids, with or without the addition of immunomodulatory therapy, depending upon the anatomic location, laterality, severity, and underlying uveitis diagnosis. Persistent and recurrent macular edema have traditionally been treated with regional or systemic corticosteroids, depending upon the laterality, together with an assessment of the vitreomacular interface abnormalities, which may contribute to chronicity, and risk factors such as smoking, which are known to potentiate this complication. Periocular and intravitreal corticosteroids have been used with variable efficacy in the resolution of macular edema, with the intravitreal approach appearing superior in clinical experience, albeit at higher rates of cataract and IOP complications. There is additional benefit of repeated injection and lower recurrence rates of macular edema in eyes on systemic therapy. Post-marketing experience with the Dexamethasone delivery system has shown consistent anti-inflammatory efficacy and improvement of macular edema in both children and in adults, and has similar efficacy in both vitrectomized and non-vitrectomized eyes. Cataract formation and intraocular pressure problems are more commonly encountered, especially following repeated injections, and the durability of the treatment effect appears to be far less than 6 months. The periocular and intravitreal corticosteroids for uveitic macular edema trial, or POINT, was a recently concluded randomized controlled trial to evaluate these regional steroids as the initial treatment of uveitic macular edema, and will be discussed in detail in the next talk by Dr. Jabs. The problem with regional corticosteroids is that they are relatively short-acting and so less effective for chronic inflammation, and associated with the cumulative risk of steroid exposure with repeated injections. There have been a variety of approaches to treat refractory macular edema listed on this slide, which we'll touch on. You're all familiar with the Fluocinolone acetonide device, which is surgically implanted and offers extended anti-inflammatory therapy, but is universally associated with the development of cataract and phakic eyes and the frequent need for medical and surgical therapy for intraocular pressure complications. In the MUST follow-up study, there was a tendency for implanted eyes to do better with respect to macular edema in the slide on the right and the graph in orange. However, this was statistically significant only at 6 months, and the trend was reversed, favoring systemic therapy at 72 months. The recently approved Fluocinolone acetonide insert offers an office-based delivery of highly effective anti-inflammatory treatment, albeit with greater cataract development. 71% of the insert eyes had resolution of macular edema, and 48% of the control eyes at 12 months. Dr. Quan Wen will discuss the 3-year results of this approach. Suprachoroidal delivery of triamcinolone has been studied in non-infectious uveitis in the phase 3 Peachtree trials, with particular attention to uveitic macular edema. 47% of the suprachoroidally treated eyes versus 16% of the control eyes met the primary outcome measure of greater than 3 lines of improvement of visual acuity. There was a robust decrease in central subfield thickness in as early as 4 weeks, which persisted and was sustained until 24 weeks in the CLS-TA treated eyes in the graph in the blue, as you can see, compared to control. There were low rates of cataract adverse events, and only 7.3% of the CLS-TA eyes required IOP-lowering medications. Intraocular methotrexate has been used as a non-steroidal alternative in the treatment of uveitic macular edema, with statistically significant improvements of visual acuity noted at 3 and 6-month time points, with concomitant reductions in central macular thickness. Intravitreal anti-VEGF agents have also been used to similar effect in eyes with inactive uveitis, with the treatment effect being seen as soon as 2 weeks after injection. There have been 2 prospective trials that have looked at ranibizumab and have shown a statistically significant improvement in best-corrected visual acuity and reduction in central macular thickness without significant ocular or systemic side effects. MERIT, a sister trial to the POINT trial, is an ongoing randomized controlled trial to assess the safety and efficacy of repeated intravitreal corticosteroids versus the ranibizumab and methotrexate nonsteroidal alternatives in eyes with controlled uveitis and persistent macular edema, and will be discussed again in the next talk. The most commonly systemically prescribed anti-TNF agents for non-infectious uveitis, infliximab and adalimumab, have a salutary effect on the resolution of macular edema with improvement in visual acuity and no apparent difference in the efficacy between these two agents. Interferon alpha-2A systemically administered has been highly effective in refractory macular edema in quiescent eyes with uveitis, however requires sustained exposure to this medication in order to maintain its treatment effect and the not infrequent development of constitutional side effects which may limit its treatment. New biologic agents such as tocilizumab, which inhibits pro-inflammatory cytokine interleukin-6 and indirectly downregulates VEGF, have been shown to be beneficial in patients with refractory uveitic macular edema in multiple case series and in 2 phase 2 clinical studies. Finally, pars plana vitrectomy may be a reasonable alternative for chronic macular edema, certainly in the face of vitreomacular interface abnormalities, and also in eyes that are refractory to medical therapy, with partial or complete regression of macular edema noted in 1/3 to 59% of cases reviewed in the literature recently. So in summary, uveitic macular edema is a major cause of visual loss, even when inflammation is apparently well treated. While regional corticosteroids have been the mainstay of treatment, office-based delivery of sustained-release intravitreal inserts and suprachoroidal delivery of triamcinolone may offer more extended treatment benefit with an acceptable safety profile. The continued study of non-steroidal alternatives, both intravitreally and systemically, as well as the role of pars plana vitrectomy, is needed in well-designed controlled clinical trials in order to inform our treatment and management decisions in the treatment of uveitic macular edema in the future. Thank you for your attention.